Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Schaefer, and I'm excited to bring to you another excellent orthopedic conversation. Today, our guest is Dr. Addison Lerner-Lentz. Dr. Lerner-Lentz is the Director of Pain Relief and Physical Therapy, which is located in Havertown, Pennsylvania. She is both COMT certified and a fellow of our academy. In addition, she's on faculty with Maitland Australian Physiotherapy Seminars. We invited Dr. Lerner-Lentz to the podcast because she is the primary author of a paper that was recently published in the Journal of Manual and Manipulative Therapy. The title of this paper is Pragmatic Application of Manipulation versus Mobilization to the Upper Segments of the Cervical Spine plus Exercise for Treatment of Cervicogenic Headache, a randomized clinical trial. As per usual, we'll link to the paper in the show notes. And with that as our general introduction, let's get to the interview. Dr. Lerner-Lentz, welcome to the podcast. How are you today?
I'm doing well. How are you doing?
I am also doing well. I am enjoying my half a day at work, and I'm also very excited not only about our newfound great weather, but to have you as a guest today, because when I read the paper that you were recently the primary author of, I thought it was a very good addition to the currently available body of evidence. And I hope you're as excited to dive into the topic as I am.
Absolutely, for sure.
Well, that's excellent. And I'd like to start by asking you what I believe is a very basic question. What was the backstory that brought you into this project and that led to the publication of this study?
So my family actually has a history of headaches. My mom had suffered from migraines for as long as I can remember. My younger brother, same thing. And I had recently, once I got into grad school and into treating, started to suffer from headaches. They would always kind of stem from my neck, and definitely I'd feel stiff, tight, and I felt if I changed my posture, I could change my symptoms, but had a hard time doing that. So during the time, the previous owner, who was my boss at the time, he very much also was interested in headaches. So the two of us kind of just put our heads together and tried to come up with an idea that made sense. He has done a ton of research in the past, and I had always told him that research was a passion of mine and would love to try to start a study. And we decided to try and get one going. So that's where the idea for the headaches came up. But I also just realized that talking with several patients that came into our clinic, even if they weren't coming for headache or neck pain, I would just kind of generally ask them. And they actually didn't realize that therapists could treat headaches. And I do feel like there is a gap in communication between patients and other healthcare professionals about how physical therapists can actually help treat headaches that stem from the cervical spine.
Well, that's amazing, and I love that story. In particular, that's the type of situation that I personally and professionally identify with. And I've literally gone from the type of person who experienced my first migraine at the age of 9 to someone that had a neck surgery at a young age, also as a child, into an adult with basically chronic, everyday, horrible head and neck pain, to at this point, maybe I get headaches 5 or 10 times a year because I was able, through the profession of physical therapy, to find a similar pathway to learn about how to evaluate and treat headaches. So again, I really identify with that story, and I'm glad it brought you into the space that you're currently in.
Yeah, so I actually found actually working on my mom first was the way I kind of made it more realistic, as she could have a headache for 5 straight days. And once I started working on her neck, how I know how to through the manual treatment, her headaches significantly decreased to the point where she was getting maybe 3 a month. That's really kind of what spurred it more and more, was that, wow, this really does make a big difference on someone who would suffer from a headache every single day. Didn't have to be severe, but a minor headache. So having her to be able to kind of practice on more or less was a great way to kind of definitely get the ball rolling.
Well, that's amazing. And I know that your mother greatly appreciates that skill set of yours. And moving forward, I noticed that this study was one that utilized a pragmatic approach.
Mm-hmm.
Can you summarize for our audience, as it relates to orthopedic manual physical therapy, the difference between a pragmatic trial and perhaps the more traditional prescriptive trial, as well as why you chose to use a pragmatic design?
Yes. So a pragmatic approach allows a clinician, physical therapist, or other healthcare professional the ability to choose which treatment they would like to do based on a patient or subject's presentation. So you're able to assess and determine, in our case, which level of the cervical spine brought on the patient's symptom quickest, or as we would say through Maitland, the most comparable sign. And that would kind of guide our treatment basis versus a prescriptive study. It is kind of outlined for you. So they are given the area or the treatment technique that needs to be done. And you are given however many bouts, however many reps, and then which exercises you want to follow up with. So the reason that we chose pragmatic was there are a couple studies out there that use the prescriptive study for manual therapy and headaches, but none that we found that used a pragmatic approach. And a pragmatic approach just is more similar to what we as therapists do on an everyday basis. We assess our patients and listen to the symptoms that they give us, and we try to treat them based on what we find or feel with our assessment. So we just found it to just be a little bit more common to kind of everyday treatment that we give in the clinic.
I think that's wonderful, and I think it helps address one of those consistent and, dare I say, even traditional variables that can stand in the way of making scientific evidence transferable over into clinical evidence. If the study is so prescriptive and not consistent with the patients that you're seeing, then how do you take those results, take those conclusions, and try to have them be applicable to the patients you're seeing in real life in the clinic?
Correct.
So moving on to the next component here, as I know you and our audience all know, any well-designed study requires specifically formulated inclusion and exclusion criteria. So that they can better understand the study that we're discussing, can you describe for the audience what the inclusion and exclusion criteria were for this particular investigation?
Yes. So for our inclusion criteria, we stuck to an age range between 18 and 65. 18 just to kind of categorize as an adult, and no older than 65, only just because once you get over to a certain age, you're starting to get into more stenotic and arthritic type conditions that could cause the referral symptoms and patterns down your arm, which was something that we were trying to avoid. Our age range was 18 to 65, and you needed to present with what we described as your cervicogenic headache presentation. So a unilateral head pain that kind of started from the base of your skull and referred or wrapped up around the head towards the eye and cheek area. It didn't matter if it stayed on the left or the right, if it switched back and forth, as long as it was a unilateral symptom. When we assessed them, if they had any joint tenderness or comparable pain between their upper cervical spine, so CO to C3, we were looking at if they had at least 2 headaches within the last month. We used the Neck Disability Index score of a 20% or higher, and pain greater than 2 out of 10 on a regular basis with their headaches. As far as our exclusion criteria, I kind of discussed that a little bit when I talked about the age range, but we were trying to avoid any nerve root signs and symptoms, so anything that did cause that referred pain kind of from the neck down the arm into the hands. So with that, we were looking at your reflexes, your sensation, checking instability. So if they presented with any of those as a positive sign, they were excluded from the study. Medical red flags, if they had any recent whiplash in the last 6 weeks. And just because our study did deal with manipulations, if you presented with any signs, we call them the 5 Ds, the dysarthria, dysphagia, dizziness, drop attacks, or diplopia, you were excluded from the study, as well as we looked to make sure that they didn't present with the 3 Ns, nystagmus, nausea, and any neurological symptoms.
Thank you for providing that picture of the patient population for us. And to make it a little bit more robust and include more content here, when you were ready to move forward after you had acquired the participants for the study, what type of outcome measures were you implementing to try and establish that baseline? And then, of course, a measure of any change over time as the treatment was being implemented?
We chose quite a few of them, actually, but it was really more or less just to try to paint a little bit of a better picture to see if we could get more changes in results. And they were comprised by looking at other research and which ones other researchers had used and which ones had pretty good reliability and validity. So we went with the Neck Disability Index just because it is found to be an extremely reliable and valid outcome measure, not only for neck pain, but also for subjects with cervicogenic headaches. We chose the numeric pain scale, again, just because for our inclusion criteria, the 2 out of 10 pain. But this outcome measure tends to show to be very reliable and very valid across all different studies, not just anything related to the neck and for headaches. The one that did pertain mostly to headaches in the neck was the HIT-6, which also stands for the Headache Impact Test. So this one actually has very good internal consistency, and it has a good retest reliability, and something that most patients could kind of correlate with. So I found that one was a little easier for them to answer and correlate with. We used the GROC as well as the patient acceptable state, or the PASS. So just to kind of determine if at the end of their treatment they felt that their symptoms were better to where they were back to functioning, or if they weren't. So it was just a simple yes or no answer that they gave us. When we did the study, we initially took the measurements on the initial visit, and then we wanted to take them again at the second visit to see if there was any change between initial visit and second visit. At that point, we then waited again until discharge. So between second visit and discharge, we didn't do any other follow-up measurements or outcome tests. And then we waited a 1-month follow-up to retest, just to see if the change that we created during that time had any long-lasting effect.
Excellent. Thank you for that description. And if I could just point out one little tiny variable, I really like the fact that you mentioned some of the clinometrics for those outcome measures. I think it's very important, yes, to make sure that our outcome measures are clinically based and understandable. Some things are really easy, like the NPRS. But when it starts to come to the more formal written ones, if we pick an outcome measure that has bad clinometrics for our population, let's say bad reliability or something like that, then it really means the results don't have a great clinically applicable thing to say about the patient population. So that's I think a really strong suit of what you were doing here, and I was very glad to see that as part of the paper. That having been said, anybody who's paid attention to the podcast clearly, for example, heard the title of the paper, so they know what the primary treatments were. However, can you dive a bit deeper into that topic and discuss for us the nature of the pragmatic treatments that were implemented?
So our study was a randomized study that used the mobilization versus the manipulation techniques. So we didn't know based on that patient if they were going to be a candidate to have mobilizations or manipulations performed. So that was hidden in an envelope that was given to the therapist. So each of them had a number on it. Each patient that came in, we were handed that envelope, and we were determined if we were going to perform the mobilization or the manipulation on that subject. However, as far as what level of mobilization we wanted to do, that was strictly based on therapist judgment. So if they were categorized into the mobilization group, we assessed their upper 3 cervical levels, so CO, C1, C2, C3. And this was done using cervical differentiation and determining which level reproduced their comparable sign. Once we found the level that reproduced it the soonest, we performed 3 bouts of 30 seconds unilateral posterior to anterior mobilizations to that patient, and they were lying prone on the table. And this was performed on their initial visit and then again on their subsequent visits after. And as far as depth or grade of movement, that was all based on therapist judgment and how the patient responded. If they were categorized into the manipulation group, then we were able to choose between a localized cervical rotational manipulation or a longitudinal cephalad manipulation. So with the localized rotational one, our assessment would be the same. So we would assess the upper 3 levels of the cervical spine, find which level reproduced their symptom the soonest or which one reproduced their comparable headache symptom. And we would do a primary manipulation where rotation was the starting point. So if you started with rotation, we ended with rotation. Whereas with the longitudinal patient was supine, we were facing the head of the patient and we were performing a longitudinal traction manip at the end of their available range. So we were taking up tension through to cervical traction and then performing a high velocity thrust at the end of their available range.
I really like the built-in variability of that approach. And as we stated previously, the clinically relevant approaches permit the therapist to make a decision along the way that's specific to the patient, and I obviously think that's a good thing. That point aside, now that we have a picture of not only the participants, but also the outcome measures that you were relying upon, and this pragmatic treatment approach, can you tell us what the results looked like after you analyzed the findings from the study?
So after treatment was done and we found the results, that it showed that there was no significant difference between the two different groups, between immobilization and manipulation. However, it did show that both groups over the course of the treatment study did improve, which we determined as a positive result. Just goes to show that whether you mobilize or manipulate a patient who has a headache, that manual therapy is an effective treatment choice for that patient. So like I said, even though there was no difference between the individual groups, overall, it was a positive finding because the subjects did have overall improvement.
I like that summary a lot, and I think you at least partially answered the next question I had for you. And that is, how do you think clinicians can and should incorporate the results from a study like this into their clinical practice?
Yeah, so again, like you said, I kind of backtracking. It just goes to show that if you're not comfortable doing a manipulation and you prefer doing a mobilization, but you have a patient who presents with that headache type symptom, that's that unilateral presentation, if they have a job where they sit a lot, their posture isn't the best, that just getting your hands on and assessing that upper cervical spine can be extremely beneficial. It could be just those gentle mobilizations at the onset of their symptom or what reproduces their comparable sign, or it could be a manipulation to that area. It depends on really just how they present, but knowing that it is effective, I think, is a great tool because it allows the physical therapist to now kind of have extra tools in their toolbox as to how to assess and where to treat. And again, if you're more comfortable with a mobilization versus a manipulation, it just goes to show that that's going to work just as well.
Thank you for that summary. And if I could sidetrack a little bit here, and I say this as somebody who does teach courses on headaches and how to use physical therapy to manage headache pain, part of what this reminds me of is what I sometimes like to refer to as the dueling scientific narratives. If you took the time to go back, probably in the ballpark of 30 to 40 years, you can find these parallel pools of evidence, one half created by the medical professionals and one half created initially by the chiropractic profession and then physical therapy later on. And you could literally use dozens of studies from one pool or the other to provide a narrative that says something that's completely different from the other side of this dueling scientific narrative situation. And I think for a long time, I've observed for a long time that all too often some folks look at one side of the evidence and say, there's no place for physical therapists to evaluate and treat in this realm. This is probably a large part of why many of our headache patients get sent to a neurologist first. They are prescribed medications, often which have very deleterious side effects. And I always just think it's a really good idea when there's a headache, especially if it's consistent with a cervicogenic headache, that these people end up in our clinics. They should be checked for range of motion. They should be checked for passive accessory motion. They should be treated conservatively from an orthopedic perspective. And so many of them will get better with our hands, which are much less likely to cause negative side effects. And I think the study that you and your colleagues have created here goes a long way towards showing that reality. And this might be a little bit of a pipe dream, but a small part of me wants to mail this to a whole lot of neurologists all across the world so they can read it and see the outcomes that happen when a skilled clinician puts their hands on the neck of somebody with headaches.
Yeah, I actually absolutely agree with that. One of my friends is a patient currently, and she has told her neurologist about the research that we do. She actually currently is now seeing someone that is a headache specialist who very much wants her to continue with the therapy we're doing just because it is helping. But on a side note, I have also noticed that since the pandemic, we're seeing more and more patients or subjects walking in the door who are having these cervicogenic headache type presentations. And it's, I think, just because posture related, how they're sitting at their desk or in a work environment that isn't set up appropriately for them because they were at their house. So I would love to be able to, like you said, reach out to more clinicians and show them how we can help them, just because with everything that's going on, there's just an influx of these presentations, and medicine seems to be the approach that most are taking versus sending them to physical therapy.
Well, perhaps we're going to have to start some sort of research movement here. And bearing the research narratives in mind, while the past is the past, we also have to move forward from a research perspective. What do you think could be the next step when it comes to this line of research and how a topic like orthopedic manual therapy can be further investigated to advance the realm of the evaluation and treatment of cervicogenic headaches?
I actually was thinking of an idea of a study that I would like to do to follow up with the one that I have done, only just because the one that we did gives a small snapshot of exercises that we had given our patients along with the manual therapy treatment. So I actually would like to see or work on more of a prescriptive approach for an exercise protocol for subjects who suffer from cervicogenic headaches. Like I had mentioned before, a lot of it stems from posture. So is there a specific kind of treatment that we could do and give each patient that is most beneficial, that doesn't take up hours or minutes of their day, but can relieve their headaches? So that way, when they do get one at work or at home, or if they're away somewhere, they have that tool that will help just reduce that symptom for them over time.
Well, if that study comes to fruition, we'll be sure to keep an eye out for it. That having been said, Dr. Lerner-Lentz, thank you for joining the podcast today. I think your paper adds a valuable contribution to the profession and to the podcast. And I thank you for joining us today to talk about it.
Thank you so much for having me.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.